Okay. What is ureterolithiasis?
Oh,
The kidney and the ureter.
Ah,
Down.
just the ureter.
Did you say renal ureter?
Ureterolithiasis. Yeah.
stones in the
Yeah, stones, yeah. So just remember that, folks. Remember that. What can, alright, let's talk about renal tumors. Okay, what's the renal tumor? What is
Kidney rings.
a kidney tumor? It's cancer, right? Usually cancer. What type of a lifestyle causes cancers? Smoking, what else? Drinking, being obese. Okay, all these elements, folks. Having a diet that's very low in fiber, high in fat. All those elements, folks, are really important. You're gonna have to need to know that for the test. So it's an adenocarcinoma that develops unilaterally, meaning it just usually develops on one kidney. The renal cell carcinomas arise from cells that of the proximal convoluted tubule. It's just describing the location of where they usually arise from. And early manifestations. Very important for you guys to know. If it's in red, it's really important. Okay, intermittent painless hematuria. Meaning the patient's going to be coming in, they're going to be urinating or micturating painless urine, but it's going to have blood inside. That's usually indicative of some type of cancer. Okay, late, of course, all the same manifestations of any progressed cancer, weight loss, dull flank pain, palpable mass in the flank area, and gross hematuria. What's gross mean?
Elasma.
Oh, I thought it was like really nasty, like, ugh, it's gross to me. Not funny? Okay. But yeah, it's a lot of urine. A lot of blood in the urine. May I switch the slides? So this is something what it looks like sometimes. That's one that's really invaded the kidney. And what happens to the tissue that it invades? It essentially destroys it. It doesn't allow it to perform its normal function. Yeah. So when it comes to the later clinical manifestations of renal tumors or renal cancer, it's going to be everything that's associated with some type of renal failure disorder. Just FYI. The way that we usually treat this is by removal of the tumor, radiation, and chemotherapy. What did I say you guys really had to know about this topic right here?
Painless.
Huh?
Painless.
That's right. Yeah, painless hematuria. Very important for you guys to know. What else? Yeah, what causes it? What lifestyle causes it? Obesity, smoking, okay, food that's high in fat, low in fiber. All those elements, folks, increase the likelihood of somebody developing cancer, in particular renal cancer, a tumor. All right, let's talk about renal cyst. Okay, renal cyst is an overgrowth of epithelial tissue. Sometimes it can become infected. Very often it becomes infected. So a cyst from the kidneys. You guys have to know that polycystic kidney disease. You have to know what that is. Cysts cause pressure on the kidney structures and compromise function. Now, what happens if you have several cysts forming on the kidney? You had a bunch of those. Let me turn off the lights real quick. You had a bunch of those.
remove the kidney.
Okay, what was that?
Remove the kidney.
You're gonna probably have to remove the kidney, right? For why though? What happens to the actual kidney though? It stops functioning. So, what do you think polycystic renal disease can lead to?
Renal failure.
Renal failure. Does that make sense though? If you have a polycystic disease, folks, it just means that's what it's called when you have several cysts. So polycystic kidney disease can actually lead to renal failure. It's very important you guys understand that. Yes.
So if you take kidney, then you don't have
Yeah, and all you need is 500,000. So hopefully the other kidney can can compensate, and still function adequately to filter everything out. So yeah, usually if both kidneys are affected, however, you're in trouble. You need dialysis. Manifestations include abdominal and flank pain. Notice how this abdominal and flank pain goes all around the different issues that deal with kidneys. So just keep that in mind as well. Voiding disturbances, recurrent UTIs, hematuria, hypertension as well, because you're killing off the nephrons. The nephrons are responsible for regulating blood pressure, usually goes up. So what can polycystic kidney disease lead to? Renal failure. Let's move on. There's no specific treatment for this one. We do, however, give analgesics, antibiotics, antihypertensives. Now, how much did you guys discuss in cardio about antihypertensives? A lot, a little bit?
Nothing.
Not too much? Let's write some stuff down real quick, okay? Had a good mark, but where'd it go? You guys can't see that, huh?
I could.
Appropriate.
Oh, yeah, we can see that.
Yeah, you can't see that. I had it right here. Anyway, what you guys need to write down are these classification of antihypertensives. I'll explain more as we go along. So, we have something called beta blockers. Okay. This is any medication. Of course, it's an antihypertensive, right? But it usually ends in LOL. Such as metoprolol. These medications have been found to be to have hypersensitivity to certain populations, such as Asian populations. It just, for some reason, it affects them a little bit more than it affects, a little bit differently than it affects your typical person. Beta blockers, medications that end in LOL, such as metoprolol, which affects specifically Asian populations, can also have a cough that's specific to beta blockers. Okay, if somebody is receiving beta blockers and they develop this cough, we have to let the doctor know, perhaps to DC it or to change the type of medication that's being used. Does that make sense? Now, beta is short for beta adrenergic blockers. Okay, you guys know what that means? Okay. When we talk about a blood vessel, when we talk about cells, okay, this one acts on the blood vessels, and there's these little receptors, and they're called beta adrenergic receptors. What does adrenaline remind you of? Adrenaline. So what does adrenaline do to your body? It's gonna cause your blood, we're talking about blood pressure, right? It's gonna cause your blood pressure to go up. So what these medications do is you give somebody a beta blocker, it blocks the beta from attaching to the beta adrenergic receptor. Beta is just a chemical, right? It blocks it, hence relaxes the blood vessel, hence decreases the blood pressure. Because it won't constrict as much. Does that make sense? Okay, write all this stuff down. Please, this you don't have to understand completely, but it's nice to know. It's good to know what happens. Beta adrenergic blockers, this is what they do. Beta adrenergic blockers, they end in LOL. Medications such as metoprolol, it affects the Asian population a little bit more specifically. They're hypersensitive to it, and it leads to a cough. Okay? Any questions so far? Can I erase this?
Yes.
Can I erase it? Okay. You guys with me so far with the whole beta blockers? Beta that end in LOL. Asian people are hypersensitive to it. It leads to a cough. Metoprolol, right? Okay. What if I tell you you have this medication? It's called atenolol. What kind of a medication is that? A beta blocker. Good. All right. Let's talk about something else now real quick. There's another type of antihypertensive medication. This is called calcium channel blockers. You guys remember when we were talking about the endocrine system, and we were talking about hypo and hyperparathyroidism, and the parathyroid gland is responsible for calcium, right? And what does calcium do? You guys remember? It helps the contractility of the muscle, right? Skeletal muscle in particular, also the heart muscle. So, if you have too much calcium in your body, if you have hypercalcemia, that calcium is going to be affecting the heart and the muscle in a certain way. So it's going to be more active as well, more strong. So what's going to happen to the blood pressure? It's going to go up. So you give calcium channel blockers, will actually have its effect on the cell itself, okay? And it blocks the calcium from going inside. Hence maintaining the calcium levels pretty normal in here. Okay? That's what calcium channel blockers do, folks. Okay. Any questions so far? And there's one more medication. These are all classifications. You got a question?
Yeah. Isn't it, like earlier you said that the LOL causes the cough.
Uh-huh.
Wasn't it the ACE inhibitors?
The ACE inhibitors? They both do, but the ones that are more specific, guys, are beta blockers. Now, there's beta blockers, calcium channel blockers, and we have another one. Angiotensin converting enzyme inhibitors. Where have you guys seen this phrase again before? Angiotensin.
In our test today.
When-
Heart.
When have you guys seen it before?
Cardio.
The renin.
Yeah, the RAA mechanism. You folks remember that? Renin, angiotensin 1, So that's where this comes in.
Just kidding.
ACE inhibitors, folks, is that enzyme, angiotensin converting enzyme. Angiotensin 1 turns into angiotensin 2, and that helps constrict the blood vessels, correct? If you constrict the blood vessels, what happens to the blood pressure?
Goes down.
Goes down.
It goes up, guys. Okay? Because the blood vessels are constricted, so the heart has to pump harder to get the blood through that narrow lumen of the artery. So this stops that from happening. This stops that from happening. Okay? These medications end in pril. Enalapril. Okay, that might be an A. I don't know. Does that make sense, though?
Can you explain it one more time?
Yeah. Angiotensin converting enzyme. What ends up happening when your blood pressure goes up is because angiotensin 1, an enzyme, becomes angiotensin 2. It's got to become angiotensin 2 in order for the blood vessels to constrict, hence bring up the blood pressure. This ACE inhibitor, angiotensin converting enzyme, it inhibits it from becoming angiotensin 2. Hence, it doesn't constrict the blood vessels, it helps them stay relaxed, hence it brings down the blood pressure. That's how that works. They end in pril. Okay? Any questions on the three classification of medications? What I just told you right now, guys, encompasses about 70% about what you guys had to know for the cardio medications. About 70%. I don't expect you guys to memorize all of it. I just wrote it up there once to introduce it. I'll be talking about it more later on. Okay? Any questions? All right, so that's antihypertensives. Okay, it reduces the blood pressure. What happens if you give somebody antihypertensives? What's a side effect that we're going to be looking out for?
Hypo.
Hypotension. Yeah, that's right. What's the cutoff for the blood pressure? When would you not give it?
Below 120 and
60 or below.
80.
Systolic. Whoever said that. Systolic below 100. Okay. Okay. If the blood pressure is below 100, folks, you might not want to give any antihypertensives. What could happen? You can bottom out. Okay. If somebody bottoms out, what can you do to bring up their blood pressure? Inject what? Do you inject calcium?
Put them in traffic, the position.
The
shock-
position.
The shock position.
You put the position,
Tran-
either Trendelenburg or supine position, right? You elevate the lower extremities. You can give saline as well, because if you give saline, it's going to expand the blood volume, the fluid volume, hence it's going to bring up the blood pressure. Does that make sense? Okay, again, I'm just talking about this stuff right now. I know it's a little sidetracked, but I had to introduce it one way or another, and I just did. We'll talk about it again, okay? All right, back to renal cysts. Now that I distracted you guys. If somebody has polycystic kidney disease, what can that lead to? Renal failure. Good. Okay. It says you can anything that relieves pain you can include. Don't apply heat, guys. Just don't apply heat. You can also provide dialysis, because remember, if you're killing off the nephrons, you don't have enough to actually filter out the blood. So you can provide dialysis. What's dialysis?
Filtrates.
Yeah, it's the artificial mechanism of actually removing all those toxins from the blood so the patient could be more homeostatic. We can also have a renal transplant, such as George Lopez did with his wife. You guys know his wife gave him the kidney, right? Or ex-wife? He divorced her? Hey, that's cool. Why'd they divorce? Oh, yes.
I heard a rumor, and I know you would probably tell me this too, Renai. Did Ken Ken die?
Unless he died like this morning.
Yeah, but remember Chris telling me, he's like, they were saying something like, on the news about it. Who? And he was caught partying or whatever, and yeah. Who?
I don't think so.
Yeah.
I would have been
It's
like,
in the news, yeah.
I don't know, unless it happened this morning. All right, let's move on. When it comes to tumors, now I'm gonna let you guys go on a break, and I'm gonna go Google it real quick. I want to know. So anyway, tumors of the urinary bladder. He can't die because he's gonna fight Mayweather soon. He's gonna fight him soon. It's gonna happen. Trust me. I know. Etiology: most common site of cancer in the urinary tract, range from benign papillomas to invasive carcinomas. Again, what's a sign, a clinical manifestation that somebody has some type of urinary tract cancer?
Urinary with blood.
blood in the urine.
You guys are nurses. Painless hematuria. Painless hematuria. Good. All right, painless intermittent hematuria, changes in voiding patterns. Remember when we talk about GI? Any type of GI cancer, changing bowel habits? Well, change in voiding patterns or habits. If it's localized, it can remove tissue by burning. It could be invasive lesions. If that happens, you do partial or total cystectomy, meaning removal of a part of the bladder or the entire thing. Switch slide. This is what they look like. I want you guys to see the top right-hand corner picture. You guys remember what the trigone is of the bladder? If you imagine the bladder being like this, okay, not when it's full, the trigone is on the bottom. It's a little triangular area where the tissue is actually a little bit different than the rest. That's what this is. Look at all this mass. These masses that are growing around it. Okay, so that's the cancer. Let's talk about BPH. Benign prostatic hypertrophy. The enlargement of the prostate gland. You guys know this stuff already, right? Okay, who does this affect? Male or female?
Yeah.
Male. What percentage of females does it affect? Okay. Enlargement of the prostate gland. what type of enzyme are we gonna see if it's elevated in the serum when this patient has a PSA? PSA. Yeah, prostate-specific antigen. Good. It's common in men 50 years old or older. Cause is still relatively unknown, but the older you get, the higher incidence that it has. Prostate gland wraps around the urethra and the seminal tubule as well. And when it's enlarged or swollen, it constricts it. So the patient has all your manifestations of urinary retention. Okay. You guys have to know these. The patient will have frequent urination, difficulty starting urination, dysuria, frequent UTIs, because again, it's talking about the patient's retaining urine, so hard, accessible for infection. Hematuria as well sometimes. Oliguria, what's oliguria mean? What does it mean?
Something in the ear, something in the
What's oliguria, guys? What's polyuria?
So it means
So the
grows
urine-
your image capacity from
Yeah.
less than 100
Yeah, just not as much as you would normally output, guys. That's what it is. That's oliguria. And you'll also have nocturia.
don't.
Good? Can I switch the slide? Yes. All right. When it comes to medical management, folks, we perform that TURP, transurethral resection of the prostate gland. Of course, first we try to relieve obstruction with a Foley catheter. What type of Foley catheter do we use?
Coude.
Coude, the coude, good. Prostatectomy, removal of the prostate gland, post-operative. So, sometimes there's different ways that we can actually remove the prostate gland. We can do it through the urethra, we can actually do it through the perineal area. However, when it comes to a TURP, transurethral resection of the prostate gland, we go inside the penis, okay, through the urethra, and that's how we obliterate the prostate and we bring it back out. You have to perform bladder irrigations. It's really important. Okay, now, usually a patient will have some type of tube, right? Some type of ostomy drain, a drainage system. That's the word I want you guys to remember. Drainage system, post-op. What happens if you're post-op, the patient comes in and it's been an hour and your output is, let's say, 0? What does that usually mean? Some type of obstruction, you're retaining. What do you do? No, not from a catheter, from a surgical drainage system. There's no output. The patient just came back from surgery. It's been 2 hours now, no output. You'd let the doctor or the RN know. That's what I'm trying to get at, okay? Initially, the urine will be pink, cherry red. That's normal. If we can't use that site, the patient will have a suprapubic or abdominal catheter or dressing because of the surgical procedure. You want to assess the dressing. So if the urine comes back initially pink or cherry red, what type of a fluid are you expecting to find or drainage on the pads? Like serosanguinous, right? Serosanguinous. May I switch the slide? Please know what a TURP is, okay guys? The transurethral resection of the prostate gland. Alright. Now, cancer of the prostate gland, folks, how do we determine it's cancer and not just benign hypertrophy of the prostate gland? Biopsy, yeah, biopsy. Malignant tumor of the prostate gland. Initially, there's no symptoms. Advanced stage, urinary obstruction. Also, sometimes it metastasizes to other places. When it comes to care, medical management, radiation, chemotherapy, or surgical procedure, same thing. Men over 70 years of age, radiation and hormone therapy, estrogen therapy, orchiectomy. Look at that word, guys. What's orchiectomy? We'll talk about this in term 4. I mean, at the end of this term, but what's orchiectomy? Removal of the testicle, or penis, or it just depends what, but in this case, of the testicle. Radiation therapy and chemotherapy as well. What's orchiectomy again? Okay, switch to slow. That's what ends up happening, guys. So look, these are 2 different types of orchiectomies. The first one on your left-hand side is abdominal. So they go in through the abdomen, they open up the pelvic cavity, they go inside and they pull through the vas deferens and the seminal cords, and they pull out the testes, and they cauterize or they burn to stop the bleeding, and that's it. Then they start suturing everything up. That's the left side. The right side, however, is a patient actually being opened. And all of those elements are taken out, yes?
Will they still be able to get an erection?
That's a good question, actually.
Or kids. Or have kids.
Depending on whether any nerve, usually yes, they'll still be able to get an erection. Yeah, that's fine.
Well, what is coming?
Pardon me? Well, there's nothing coming out.
They couldn't have babies.
That's right, they can't have babies. So before this, they usually have you. Now, this could be done, guys, if somebody had like testicular cancer or something. Maybe a metastasized to the lymph nodes around there, to the tissue around there. So they'll have that done as well. The darker pigmented section on the right-hand side, folks, is a scrotal sac. But notice how it's so small now because there's nothing in there to keep it.
Where?
Right. Yeah.
Sack.
That's supposed to be the scrotal sac, yeah.
That? Oh, that's not part of there.
It's the scrotal sac. So typically, there's something inside. Testes are inside. In this case, there's not.
Wow.
Wild, right? So urethral strictures, folks. Narrowing of the lumen of the urethra that interferes with urine flow. Pay close attention, folks. Whether it's a urethral stricture or stones, these will all lead to fluid backing up into the kidneys. Okay? So I'll talk about that in a little bit when we get to nephrotic syndrome and nephritis, pyelonephritis, and all that stuff. And there,
Fluid leading back to.
well, no. What I want to say is this: due to a urinary stricture or ureteral stricture or stones, there's backing up of urine going back up the urinary tract. So it can lead to the kidneys and it can cause them to dilate. If there's some type of bacteria in there, it can lead to something else as well, and I'll talk about that in a little bit. All I'm saying is that urethral strictures can lead to those things. I want you to understand what's happening. Okay? It's being constricted, so the fluid isn't passing by, it's all backing up. Narrowing of the lumen of the urethra that interferes with urine flow. It can be congenital or acquired. Clinical manifestations include dysuria, nocturia, weak urinary stream, pain with bladder distension as well. Of course, we want to correct the stricture through some type of surgical intervention, and we can also provide analgesics. Now, we could also provide antispasmodics. Okay, so keep that in mind.
Why would you give that antispasmodic for this?
Because if you think about the tube coming down, right, and it's constricted, it interferes with the integrity of the muscle. So sometimes that causes some nervous misfires, and it causes the muscle to kind of contract a little bit and spaz out. So you give it, and that also contributes to more of the stricture, and it contributes to a lot of pain as well. So that's why you give antispasmodics as well. Anticholinergics as well, because it stops the secretion and it stops the motility of that particular organ as well. All right, urinary tract trauma is only talking about some type of damage due to a physical injury. Injury to the urinary tract may result from accidents, surgical intervention, and fractures. You guys ever heard of a fractured penis?
No.
Okay, well it does technically happen. That can lead to this as well. Okay, usually during intercourse, the phallus gets struck too hard from the meatus, and it actually tears off from the pelvic bone, and it's considered a fracture. They put her in a cast and everything. So anyway, anytime there's trauma, folks, to that particular tract, you'll have hematuria, abdominal pain and tenderness, all that good stuff. What's going to differentiate this issue from all the other issues that also have hematuria, abdominal pain and tenderness? This one has to have history with it. Patient had some type of accident, and that's how we know that this might be going on. You guys good so far? Some of you guys look like zombies. You guys sleeping enough? Wake up, guys, wake up. Wake up. May I ask what the slide is? Yeah. All right, nephrotic syndrome, really important. This is super important. There's like 30 questions on this and all its components on the exam, folks, so make sure you guys understand this. Yeah, nephrotic syndrome, folks, is just physiologic changes at the kidney, meaning structural changes with how everything works, with the nephron, of the glomeruli that interfere with selective permeability. What does that selective permeability mean?
What it is and what it isn't.
Well, essentially what it allows to go through and what it leaves back. So, when we talk about all this stuff right here, passing on through, there's a membrane that surrounds the glomeruli, folks, and that's selectively permeable, meaning certain elements that are too big will stay behind. Okay, elements that are small enough will actually pass on through. So that's what selectively permeable means. So we have elements that pass on through the proximal convoluted tubule, such as proteins. But what happens in this proximal tubular area? It gets, what's it called? Yeah, renal threshold. It all gets reabsorbed. So that's why proteins and sugars and all those elements aren't supposed to be in the urine. However, when you have nephrotic syndrome, there's something wrong right here. There's something wrong. It doesn't allow selective permeability to occur accurately. So you have elements that aren't supposed to be in the urine come out. And that's the real important thing that you guys have to know. Okay, that's why the clinical manifestations include proteinuria. We spoke about albumin being a protein. So if you have protein, in particular albumin in the urine, okay, that means that it's leaving the body and you're not supposed to have that. Proteins aren't supposed to be in the urine. Remember those are one of those elements that aren't supposed to be in the urine? So keep that in mind. Now, if you're getting rid of the protein, you're getting rid of the albumin, you'll have hypoalbuminemia, meaning the protein level in the blood will be low because you're getting rid of it. Does that make sense? Okay? If you have proteinuria and albumin is a part of proteinuria, you're getting rid of protein, the serum level of your albumin or the serum blood test of the albumin or the protein will be low because you're getting rid of it. You'll have generalized edema, also called periorbital edema. Usually you'll see it in the eyes and the face, also known as anasarca. Okay? You'll have anorexia, fatigue, and oliguria. A little bit of urine. Okay, but you'll still have proteins inside because remember, it's no longer selectively permeable, so all the junk is coming out, some of the stuff that we actually need, but the urine itself isn't forming adequately because the nephron is damaged. May I switch the slide? see you like. You good? Alright, so this is kind of what it looks like. We can give corticosteroids, we can give diuretics. Okay, what's that called on the right hand side? Periorbital edema. Periorbital edema. We can give corticosteroids, we can give diuretics. Hell, we could give cyclosporine, which is an anti-neoplastic medication as well. But these are the two most common ones we give. Diuretics, you want to give a low sodium, high protein diet. Why do you want to give low sodium?
So
You don't retain fluids. Why do you want to give high protein? You're getting rid of it, so you need more protein inside the body. And if you don't have protein, you don't have the adequate ability to maintain skin integrity. You'll develop decubitus or skin ulcers. Good. Now, nephritis, also really important, guys. Nephritis, super important. The first thing I want you guys to know about nephritis is that it's also called glomerulonephritis, meaning the glomeruli is inflamed. And the glomeruli is where filtration occurs. So this is the basis of the entire homeostatic property of the kidney. So if that's wrong, if there's something wrong with the glomerulus, folks, the patient's going to get really sick. I want you guys to understand that. Before we move on, what does polycystic kidney disease lead to?
Renal failure.
Okay, good. So, when it comes to nephritis, this is talking about acute glomerulonephritis. This is when it's it's a sudden onset. It's usually preceded 2 to 3 weeks before you develop the kidney issues. You had some type of an infection, usually upper respiratory infection. B. Hemolytic streptococcus, that's what it's called. You guys have to know that. If a patient comes in with hematuria, let's say, okay, or some other elements of abnormal renal function, and then in their history, the patient tells you, oh, you know what, I had an upper respiratory infection 2 weeks ago. What do you think they're gonna have? Some type of nephritis. Okay, does that make sense? You had a question? You can ask me. If I don't know, I'll just be like, I don't know. Write it down, ask me later.
Yeah.
Send her a message.
What were the meds again? Sorry.
Corticosteroids?
Or-
So again, folks, please remember this. Nephritis is any type of inflammation of the kidney. The most common one that we're dealing with is acute glomerulonephritis. That's the inflammation of the glomeruli, acute because of this particular upper respiratory infection. Okay, the type of, and you guys understand that, why it's called B. hemolytic streptococcus? This is all it means, that for a lot of people that eventually get diagnosed with glomerulonephritis, meaning the inflammation of those kidneys, about 90% of them had some type of upper respiratory infection 2 to 3 weeks before that. They were exposed to it, and somehow your kidneys picked it up. Okay, because your immune system was a little bit compromised. We really don't know why, but that has to do with it. And that's why it's so specific, because over 90% of the cases of acute glomerulonephritis had a history 2 weeks beforehand with upper respiratory infection. B. hemolytic streptococcus. You have to know that pathogen. B. hemolytic streptococcus. You guys have to know it. Or also a pre-existing multi-system disease. May I switch the slide? All right. So now let's talk about the manifestations. There's a lot of stuff here, guys. Write all this stuff down or whatever's not on your PowerPoint. So you'll have edema of the face, periorbital edema. Okay, this is for acute glomerulonephritis again. It's the hallmark sign of acute glomerulonephritis, the periorbital edema. What does the hallmark sign indicate? What does that mean?
The main.
The main one, the classic one for this particular condition. Anasarca, generalized edema, also sacral edema. This is very common. Usually they develop sacral edema. You want to maintain skin integrity whenever you have a patient that has edema, because the fluid goes into the interstitial cavities, okay, and they thin out the skin, making it a lot more susceptible to breakdown. You have pallor, malaise, anorexia, dyspnea with exertion, hematuria. Now, pay close attention to this, guys. The patient will have hematuria, blood in the urine. However, they will also have urine that's tea-colored or cola colored. Okay, so that's also very classic. A patient comes in with letting you know that the patient had a B hemolytic streptococcal infection 2 weeks prior to that, and you check their urine and it's the color of Coke. What do you think they potentially have?
I'm sorry.
It's okay. Glomerular. There you go. Glomerulonephritis. Okay, acute glomerulonephritis. It's very specific. Changes in voiding patterns, oliguria, again, a decreased amount. Dysuria, usually less than 100 mLs in 24 hours. So that means when you develop acute glomerulonephritis, folks, it's very serious. Okay? Very serious. A lot of times it's less than 100 mLs in 24 hours. It may lead to hypotension. You want to assess LOC. Now, when it comes to it may lead to hypotension, well, when we look at the treatment, it'll say increased fluid intake to bring up the blood pressure. It goes both ways, but it may lead to hypotension eventually. So just keep that in mind. So that's one of those elements, folks, that it's very trivial. So I'm not going to be asking you, I'm not going to be telling you the patient has hypotension, and based on that element, what does the patient have? No, it could be hypertension, but Coke-colored urine, B, streptococcal infection, those are very important elements that you guys are supposed to become familiar with. And you always want to assess for changes in the level of consciousness when you suspect somebody to have a drop in BP, because they're not perfusing the brain adequately. Okay? What color is the urine for acute glomerulonephritis? They can also have hematuria. Okay? All right, good. What's a hallmark sign of acute glomerulonephritis? Periorbital edema. Good. All right. Oh, sorry. Yeah. Switch the slide, please. Almost. Alright. Let's move on. You want to give, of course, antibiotics because of what's a very common antibiotic that we give? Bactrim. But for this particular one, we have to culture it, do a sensitivity to see what other medication is specific for this one. You give diuretics, you give antihypertensives. You saw that, guys? See, it said it may lead to hypotension, but then you give antihypertensives. But that's why, because it could be varied. It could be up or down. It just depends on the progression of the condition. You want supportive management, very similar to palliative care, folks. Just treat the signs and symptoms. Diet, protein and sodium restrictions. At this point, the reason why you want to restrict proteins is because your glomeruli have a hard time filtering it out. So you want to decrease the amount of proteins that are going inside. You want to decrease the amount of sodium because you're retaining fluids. Okay? And of course you want to increase the calories. When you say you want to restrict proteins, it doesn't mean you don't give them any. Okay? You just decrease the amount. Okay? Or you give very lean protein, like just chicken, versus that, and then peanut butter and some other elements like that. You know, so you just give them things like that, but you do want to watch out for how much protein you're giving. May I switch the slide? All right, nephritis. So still talking about chronic glomerulonephritis. Slow progressive destruction of the glomeruli, commonly caused by other chronic illnesses such as diabetes, such as lupus. I think, what's his name? Nick Cannon, I think, got this at one point. What was that?
Seal has it.
Oh, Seal has it. Tony Braxton. So yeah. So same thing, guys. When it comes to what's wrong, except it happens in a longer period of time, you do to some type of debilitating disease, such as DM, systemic lupus. Clinical manifestations, of course, malaise, headaches, dyspnea with exertion, visual and digestive disturbances, generalized edema. Please know that word, folks. Anasarca. Weight loss, fatigue, hypertension, anemia, proteinuria, and usually the urinary analysis shows the protein. So write that down, guys. Next slide. Alright, and medical management is the same as acute glomerulonephritis. Sometimes you may need renal dialysis or a kidney transplant. That's it, guys. Okay? For this. Okay. Go on a break.